So I'll be presenting on my topic now. I'm from AIMS, New Delhi, India. This is my disclosures. The project received an intramural fund from our institute. These are my co-authors. So low pressure pneumoperitoneum is an attempt to make laparoscopic surgery even more comfortable and safer for the patient. And lower postoperative pain and faster recovery has been demonstrated in the literature. Studies have demonstrated that deep neuromuscular block can help in increasing the working space, which is actually lower in the case of low pressure pneumoperitoneum. So, however, there's a lack of literature directly comparing low pressure pneumoperitoneum with deep neuromuscular block with standard pressure pneumoperitoneum with moderate neuromuscular block, especially with objective evidence of inflammatory markers. So the research hypothesis was low pressure pneumoperitoneum with deep neuromuscular block causes lesser inflammatory marker rise compared to standard pressure pneumoperitoneum in patients undergoing laparoscopic cholecystectomy. The primary objective was to measure and compare the inflammatory marker levels in both these groups. And the secondary objectives included the pain scores, the incidence of complications, conversion rates, and length of hospital stay. So it was a single institution, prospective, single-blinded, randomized control trial, and subjects were allocated into group A and B according to a computer-generated sequence. And the group A was the one, the patients underwent a laparoscopic cholecystectomy under low pressure of 8 to 10 mm Hg with a deep neuromuscular blockade. And group B underwent a standard laparoscopic cholecystectomy with moderate neuromuscular blockade at a pressure of 12 to 14 mm Hg. We included all the patients who underwent laparoscopic cholecystectomy from April 22 to March 23, who were included in the criteria. And we excluded patients with extremes of age, extremes of BMI, and any prior inflammatory conditions which could affect the results, and those who refused consent. So the sample size came up to be 80. This was considered due to the feasibility of resources and cost constraints, which was required for the ELISA kits required to measure these markers. So the intervention was the group A, the low pressure group received a cisatracurium infusion at a rate of 0.1 mg per kg per hour. And the deep blockade was monitored using NMT, which kept the TOF at 0 and the PTC at 1 to 2. So the low pressure usually was started at 8 mmHg and increased only if required. And group B was a routine moderate neuromuscular blockade with TOF of 1 to 3 and standard pressure of 12 to 14 mmHg. And the reversal agent was routinely a neostigmine. And all of them underwent a routine 4-port laparoscopic cholecystectomy. The inflammatory markers were measured preoperatively for a baseline value and also postoperatively 24 hours later. And the ELISA kits were used for measuring the markers such as interleukin 6, 1 alpha, 17, and TNF alpha. Appropriate statistical tests were analyzed, and a p-value of less than 0.05 was considered significant. Coming to the result, baseline demographic values were similar in both the groups, and a majority patients were female, and this was the consort diagram of our study. So there was no loss to follow-up since the patients were in the hospital itself. So this was the table of results. All these blood investigations show that numerically there was a higher rise of in group B compared to group A. However, it was not statistically significant. But when it came to serum albumin, the fall in group B was greater compared to that in group A. Suggesting, since it's a negative phase reactant, suggesting there might have been lesser inflammation in group A. Also, serum cortisol serum cortisol fall was greater in group B, suggesting there might have been a higher stress response because the negative feedback usually suppresses the ACTH. And other than that, liver enzymes like AST, ALP also showed numerically higher rise. However, it was not significantly high in group B. And this might suggest Planck-Neck ischemia. So this was a graph of the rise in inflammatory markers in group B compared to group A, which is in blue. And also the postoperative pain was significantly higher in group B at both 6 hours and 24 hours postoperatively. So there were no intraoperative or postoperative complications in both groups, and no side effects like residual paralysis, delayed awakening, or pulmonary complications. There were similar extubation times, hospital stay durations, and there were no conversions from low to standard pressure group. However, 4 patients required increase in pressure from 8 to 10 mmHg to improve the working space in group A. And a brief discussion, a previous study from our institute showed that non-inferiority was established in terms of working space when deep neuromuscular block was used. And the present study indicates lesser inflammation. It may indicate lesser inflammation, giving the objective evidence which may be required. So there are various studies which demonstrate lower inflammatory markers in low pressure groups. And also there is better recovery and lesser postoperative pain, which is showed in the literature. So this was a randomized control trial and a prospective study, and blinding of patient could be achieved. However, the limitations were there was no blinding of the surgeon and a small sample size, which may not have been powered for the exact result. And also the markers required to be stored for some duration before we actually measured them, because they required to be measured at once. And that was stored at -80 degrees, so that could affect the values finally. And so in conclusion, low pressure pneumoperitoneum with deep neuromuscular blockade may cause lesser inflammation and pain compared to standard pressure pneumoperitoneum. And so we could recommend that we can start the surgery with a lower pressure, and may use a deep neuromuscular blockade and increase the pressure if needed in intraop. So thank you. Any questions I could?